Greetings from eMedinexus, an IGCP group of publications. I'm Dr. K.K. Agarwal, Editor-in-Chief of the IGCP group. Welcome to our show, Chat with Dr. K.K. For today's chat, I have two experts in inflammatory bowel disease. Both of them are GI experts. To my right is Dr. Vineet Ahuja, who is a professor, Department of Gastroenterology and Human Nutrition, All India Institute of Medical Sciences, New Delhi. To his right is Dr. Vijay Yajnik, who is the Director, Crohn's and Colitis Center, Mass General Hospital, Harvard Medical School, Boston, US. Welcome to our show. So, Vineet, when we talk about today, in this segment, we are going to cover mainly inflammatory bowel disease, general aspects. So when we talk about inflammatory bowel disease, is it common in India? Because when we were in our medical school, Crohn's was practically non-existent. Ulcerative colitis always used to be misdiagnosed as amoebic colitis, giardia infection, and in very few cases we used to see actually ulcerative colitis. Is it really common in India now?
Yeah, as you have said, inflammatory bowel disease consists of two kinds of diseases. One is ulcerative colitis, the other is Crohn's disease. If you look at the number of cases we have had, the studies done in India, then ulcerative colitis was always there in India, although maybe it was not recognized so much. One. Secondly, maybe the awareness was not so much amongst the general practicing people and even amongst the bigger hospitals. Two. Thirdly, the tools which were there for diagnosis were not readily available. When I talk of tools, means colonoscopy or sigmoidoscopy. So ulcerative colitis was there, and now also like we see plenty of cases of ulcerative colitis. Whereas the same thing does not hold true for Crohn's disease. Crohn's disease was definitely uncommon in India, maybe around 20, 30 years back. And all of us, when we were studying, if a diagnosis of Crohn's disease was made during examination, that candidate was sure to fail. This is a common story which circulates around, and that is true. But today, if you get a case and if you do not make a diagnosis of Crohn's disease, then you're surely going to fail. It has become that much so common, and that much so there's so many such cases come to us. And these cases are seen much more. The Crohn's disease are seen much more in South India, whereas ulcerative colitis cases are seen much more in North India.
So in terms of chronic diarrhea, so if I see in my practice 100 cases of chronic diarrhea, how many of them will end up with the diagnosis of ulcerative colitis and how many Crohn's disease?
So when we get chronic diarrhea, we divide them into whether it is small bowel diarrhea or large bowel diarrhea.
So say before that, let's go more basic. What is chronic diarrhea?
Chronic diarrhea is whenever you have diarrhea which is defined as an increase in the stool frequency or change in stool consistency. Generally, we take a arbitrary value of more than three bowel movements a day. If that is there for a duration of more than 4 weeks, we call that as chronic diarrhea. If the symptoms of malabsorption are there, then it tells us that the diarrhea is most likely small bowel diarrhea. I'm not going into much details about it. However, if the patient has diarrhea with rectal symptoms like urgency, tenesmus, if there's blood in the stools, then you know that you're dealing.
So to make it more simpler, can we say acute small intestinal is the same symptoms if they persist for more than 4 weeks, like means watery diarrhea, no less of mucus, no blood, no pain.
Any kind of diarrhea persisting for more than 4 weeks is chronic diarrhea. Chronic diarrhea.
No, in terms of small versus large intestinal, painless, effortless, pain.
It may not be painless. It will have blood in the stools either.
No, painless will be small intestinal.
Yeah, small intestine will be painless, but if it is because sometimes tuberculosis can also cause a Crohn's disease, can also cause small bowel diarrhea. There may be episodes of pain, but the pain location would be very unlikely in small bowel diarrhea. In large bowel diarrhea, there is pain, then the pain location would be on the flanks. So large bowel diarrhea, if you get 100 cases, the commonest cause would be irritable bowel syndrome. That's a functional bowel disease. If we take, let's say, 50 cases of which would be attributed to irritable bowel syndrome, then the next commonest cause today, I would say in India, would be, in terms of chronic diarrhea, not acute diarrhea, would be ulcerative colitis. Thereafter, we can think in terms of Crohn's disease, intestinal tuberculosis, and if the patient is elderly, then we have to also rule out malignancies.
So again, I come back to 100 cases of chronic diarrhea. What is the chances of having ulcerative colitis?
Chances of having ulcerative colitis, as such, I would not be able to give you a figure for 100 these kind of cases, but yes, maybe like we have a prevalence of around 42 per 100,000. In 1 lakh population, there would be 42 cases of ulcerative colitis.
And Crohn's?
Crohn's, the definite prevalence is not known, but would be somewhere roughly. If I just, I would guess, I would say this figure because this figure is not available, would be 5 to 10 per 100,000.
And what about in US, Vijay?
Thank you for the opportunity. What we see is, I'll just try to summarize what we initially talked about. In any world, any population, first of all, Crohn's disease and ulcerative colitis were initially thought to affect Jewish people. That was the original idea, but it's now expressed in every community: African American, Indian, Chinese, anybody can get it. In every community study, ulcerative colitis comes about 40 years before Crohn's disease. So ulcerative colitis came in Europe in the late 1800s, and early 1900s, Crohn's was described. Similarly, we saw ulcerative colitis more in the 1960s in Delhi, and now we are seeing 40 years later a little mixed picture. Second thing I want to say is that for us, when you have chronic diarrhea, the majority of patients have irritable bowel syndrome. We have about 1.2 people in America that have Crohn's disease or ulcerative colitis. It's 50-50 split. So our percentages are about 1 in 100 will have either Crohn's disease or ulcerative colitis.
1 in 100 of population or 1 in 100 of chronic diarrhea?
But I don't think anybody has seen that's an excellent question, because you're really targeting the primary care and the general practitioner. I don't think that's really investigated, because if it's an academic center, then the numbers of chronic diarrhea, Crohn's and ulcerative colitis go higher. If you're in a peripheral center, you see it much lower.
So if I have to go back again, that if a GP is examining a patient with chronic diarrhea, when should he refer to rule out ulcerative colitis or Crohn's disease?
I think the referral should basically depend in the duration of symptoms. As you know, most infections are self-limiting. They last for a few days and the people get better. So acute colitis from infection is very short term. So my view is, if you have 3 to 4 weeks of diarrhea, but if you have diarrhea with alarm symptoms, which is mucus and blood.
See, mucus and blood in India is the commonest thing. With maybe colitis, you will get in every patient lasting for more than 4 weeks.
It has to be investigated.
So any diarrhea, chronic diarrhea, small intestinal or large intestinal, if it is prolonging, and if it is lasting for more than 4 weeks, the patient needs a referral.
I think we can come to this consensus, yes. We can come to a consensus on
any diarrhea lasting for more than 4 weeks should be referred.
Send for a
Yes.
Send for a what? Sigmoidoscopy, colonoscopy.
Again, then the patient's history needs to be taken.
I would say weight loss. Alarm symptoms are critical. Weight loss, inability, pain, disproportionate symptoms, and patient comes in and has chronic diarrhea but has 30 pounds or 15 kilogram weight loss. That's very serious. You don't need to wait.
So I said, now the patient, he wants to refer the patient. He refers it to whom? For what? Straight away, patient goes to a sigmoidoscopy or a colonoscopy, or
he refers to a gastroenterologist. A gastroenterologist decides.
Gastroenterologist may not be available in every city, so therefore.
You take the history. The patient has small bowel diarrhea or large bowel diarrhea. Suppose the patient has blood in the stool, then straight away sigmoidoscopy. Let's say the patient does not have blood in the stool. The patient has mild anemia, some amount of weight loss, painless diarrhea. Then we would like to think in terms of celiac disease, a small bowel diarrhea, or a tropical stool. So it depends upon what kind of history the patient has. If the predominant large bowel symptoms, yes, you then would like to go in for a sigmoid.
So we'll go one by one. So suppose the patient has 4 weeks of diarrhea with blood, suggestive of a large bowel disorder. Now he refers him to a physician or a GI, whosoever, whether a physician doing GI practice or a GI specialist, and he refers him for what? Should he write down referred for sigmoidoscopy? Should he refer for opinion, or referred for colonoscopy?
I think he should refer for opinion first, because no procedure is risk-free. And I think if the patient is having a colonoscopy or an endoscopy, it's nice that the patient and the doctor and the gastroenterologist treating physician understand the questions. And so it's not like a radiology test that you order a CT scan and it requires a little more, and same thing as you see in cardiology. I think the more the doctor understands, the better delivery.
I'll tell you why did I ask this question. I'm basically, so when I refer for a sigmoidoscopy, okay, suppose I am a senior physician referring it to a GI, or a senior family physician referring it to a physician. When I say refer for to rule out ulcerative colitis, referred for colonoscopy or a sigmoidoscopy, the person is not supposed to, he's supposed to do the procedure, diagnose, and send it back. Okay. And then if I refer it to opinion, 90% of the people may not come back to me. I will lose my family, I'll lose my patient. Therefore, as a family physician, I want to be clear for what I'm referring. Because if I'm referring him for an opinion, he will say, okay, take this 4 weeks treatment, come back to me again after 4 weeks, I lose the patient. And that is a apprehension amongst, and that's the reason in our hospital, that's the reason in India, the referral rates are very low. Because people are afraid my patient is not going to come back.
In that case, one should follow the algorithm that if a patient has chronic diarrhea and the physician is sure that the patient has large bowel diarrhea in terms of blood in the stools or rectal symptoms like urgency, frequency, and tenesmus, adequate course of antibiotics has been given. When I say antibiotic, adequate course is minimum 5 to 7 days of imidazole, that is metronidazole or cetronidazole, along with the quinolone has been given. The patient has not responded. Patient continues to have increased stool frequency, daytime as well as nocturnal, with blood in the stools. Then then you know there's a colonic pathology. Then the patient may be referred for sigmoidoscopy. But if adequate antibiotic dose has been given.
Okay. Now suppose I'm suspecting as a senior family physician or a physician, I'm suspecting clinically this is ulcerative colitis. In my mind, I'm sure. I want to start the treatment of ulcerative colitis. I want a procedure to be done for a confirmation for which because I myself don't do any other procedure. So should I refer him by writing sigmoidoscopy or a colonoscopy? Or sigmoidoscopy is sufficient? Because the charges for both in a private sector are different.
Depends upon the disease severity. Colonoscopy may be contraindicated if the patient has very serious symptoms. Colonoscopy runs the risk of perforation if the patient has severe. So best is first investigation should always be a sigmoidoscopy, and that also the gastroenterologist should have the decision, make the decision whether the patient is in a state to undergo the sigmoidoscopy and all, or sometimes a very limited examination without preparation is enough.
So as a family physician, I write down sigmoidoscopy to rule out ulcerative colitis or to confirm ulcerative colitis. Sigmoidoscopy with a biopsy to rule out, and I can even put down is that if colonoscopy is indicated, either go ahead or discuss with me. Yes. I can give the instructions to them that they can talk to me if they feel that sigmoidoscopy is necessary. Then the doctor should talk to me on phone and take my permission, take my consent to do that. Okay. Now, if I now suspect on the contrary a small bowel diarrhea, chronic diarrhea, what is the investigation of choice? Let's say I've done the X-ray. X-ray is negative. Okay, I have done the celiac test. The celiac test is negative. For that, I don't need to refer it to a specialist. Suppose that clinically I want to rule out a celiac disease. I've done the blood test. Now I want to rule out either a tuberculosis or I want to rule out a Crohn's disease. And if in my mind as a physician, I have two differential diagnoses, TB versus Crohn's, I refer it to a specialist. What do I write down on my prescription? Refer for what?
You need a colonoscopy for that because you have to be sure that the biopsy of the terminal ileum is done because it's small intestinal thing. And we are very fortunate that colonoscopy most gastroenterologists can easily intubate the terminal ileum and take a biopsy. So that there's a visual features and histology features put together can differentiate between these two.
And that will be able to differentiate between the tuberculosis and the Crohn's disease.
It's not 100%, but sometimes it takes time to figure this out. The obvious choice is not that one simple test. And this type of, I think the relationship and a clinical relationship with a gastroenterologist is very critical in this one.
Now, why did I ask this question? I have three options with me.
Here in India, we would like to defer it.
No, I'll come back. I have three options with me. Do I send it for a CT enterocolitis or a MRI enterocolitis? For that, I need to refer it to a radiologist. If I go to a colonoscopy with the terminal ileum viewing, I need to refer it to a gastroenterologist. Do I go for a barium testing? Traditional, old, and many people still vouch that we give you complete diagnosis even with the advanced techniques of barium. Again, I need to refer it to another radiologist. So I'm in a fix where to refer.
I think if you're very suspicious of a diarrhea and you're really thinking about Crohn's or
And one more, because now people are, anything new comes, there are a lot of advertisements. Now everywhere you're talking about, everybody's promoting capsule endoscopy. So therefore, I have three options where to send. And I don't want to send it. I really want to take a decision myself as a physician, that in which situation capsule endoscopy, in which situation colonoscopy, and in which situation CT entero or MR entero at the first step.
I may differ from
No, you say how in US, then let him say how in India.
I think to me, a diagnosis based on histology is critical because the treatment can have dramatic results. So if it's Crohn's disease, we typically give immune suppression steroids, and if the patient has TB, they would become catastrophic. The patient can die. So while there's a lot of advance in radiology, it's very limiting because you cannot do a biopsy. I don't think any radiologist can look at a scan and say this is TB versus Crohn's. There are some studies that say some features are more suggestive of Crohn's, but it's not that specific because the treatment is so dramatically different. It's a big burden on the treating physician to really be sure what they're doing.
What about in India now?
I would not go with any of your choices, all four of your choices. I think what we do is the investigation we would do in such a setting would be CT enterography, not an enteroclysis, a CT enterography.
What is the difference?
The CT enteroclysis is where you put in a tube, right? So you put in a tube and then you put in the methyl cellulose or the negative contrast through that, so that it distances retinol. But then that causes a lot of discomfort to the patient. CT enterography is where the patient just prints the neutral solution or the negative solution, and as a result, that distends the small bowel well, and you can have a cross-sectional imaging also in terms of lymph nodes. That's a non-invasive test. That gives you the roadmap very clear, whether there's any structure out there or not. If there is no structure, there is an area of enhancement, whether there are any lymph nodes. After CT enterography, then we decide.
Why not MR enterography?
MR enterography is a preferred investigation of choice because it does not involve any radiation. And if a patient has Crohn's disease, he may have to undergo multiple CTs over a lifetime, so he would like to reduce the risk of it. But across the board, if you talk to the radiologist and everybody is still more comfortable if the first time a CT enterography has been done. So it's more easily readable in terms of like the people are across various cities are better equipped to read CT enterography. They're more conversant with it. And subsequently, the next time if it has to be done, then it may be an MR enterography. So you do a CT enterography. Then after that, I totally agree with him that you would have to do a colonoscopy, and histology is very critical for diagnosis. But first is to get the whole roadmap of that thing. And that also decides whether you can do a capsule or not, because capsule often gets stuck in tuberculosis or Crohn's disease if there's a stricture. That becomes a contraindication for a capsule. And if capsule gets stuck, then you have to do surgery at times to get the capsule out. So a CT enterography will also tell you if there is no stricture, and if you want to investigate further, then you would do a capsule. However, if there's a stricture, then obviously capsule endoscopy is done. So what we would do is if IgA TTG is negative, then I would if that is negative, then before CT enterography, in fact, if you're suspecting small bowel diarrhea in terms of patient has anemia, patient has hypoalbuminemia, patient has hypocalcemia, then one would like to do an upper GI endoscopy with a duodenal biopsy first before going into CT enterography. Then a CT enterography.
Duodenal biopsy will rule out?
Duodenal biopsy again for tropical screws, celiac disease, immunoproliferative small intestinal disease, if that is something which we see out in giarditis is one of the common causes of small bowel diarrhea, chronic small bowel diarrhea, which we see frequently. And if you do a duodenal biopsy, you may pick up giardia, which you may not be able to pick up because stool examinations are often said should be done, but people do not end up doing it diligently for 3 days or 4 days. So upper GI duodenal biopsy and tuberculosis at times can be picked up. Similarly, if you think of Crohn's disease also diagnosis can be facilitated, cannot be confirmed, but be facilitated by a duodenal biopsy. So do that, then do a CT enterography, then do a colonoscopy plus terminal biopsy. Still, you're not getting a diagnosis. There are signs in terms of the patient has symptoms in terms of patient has abdominal pain, weight loss. There are signs in terms of like the patient has anemia. Then you can think in terms of going for a capsule endoscopy. That should be the last investigation.
So if I have to choose, then the colonoscopy and CT.
We would go upper GI small bowel diarrhea, upper GI endoscopy, duodenal biopsy, CT enterography, then ileocolonoscopy with a biopsy.
Okay. if I say in India that whatever you do, whatever statistics they may have in US, in India, when you end up into a Crohn's disease, you end up into a treatment of a tuberculosis first. In most of the cases, not all, in many of the cases, there is a trial. So here, there I want to come back is there a role of gene expert test? When you take a biopsy, is there any guidelines available? These guidelines has to come from India because
We don't see this, so we don't really have, you're correct. I think, but molecular techniques like PCR could potentially help, but I think it has to be done at a very an established lab.
it is not. In India, it is established. It is now coming as because for MDR and for XDR TV, and then Clinton Foundation is working with most of the top institutions, and they have really the charges are only 2,000. It's fixed by the government. Now the government is coming out with guidelines. I know the gynae guidelines are almost over. They are now coming out with guidelines. The government of India, the CDT.
I'm part of the group which is making the guidelines that we make by Dr. S.K. Sharma.
Yes. So is there anything we are trying to work on a diagnosis of tuberculosis? Because if you do a biopsy and if you do a gene expert and if a study can be done in the country and it can rule out tuberculosis, it will really help.
What we have put in the guidelines for abdominal TB, for gene expert, we recently completed a study whereby we took biopsies, colonic biopsies from patients with tuberculosis, from patients with Crohn's disease, and other biopsies where colonoscopy was being done just to study what happens to when you do a gene expert. So gene expert was negative in other diseases, but was positive in TB, but in only 4 out of 37 cases of TB, suggesting that the sensitivity is very poor. So gene expert right now has been validated for pulmonary, for the sputum samples. For extra pulmonary samples, the validation study is going on. Our initial data on colonic biopsy suggests that it is very specific, but it is not very sensitive.
So if positive, this confirms. If negative, it may not.
Positive, again, as a standalone test, I won't say it confirms. It is not like sputum sample or something like that. It just suggests. That is the problem with the standard tuberculosis.
Yeah, but if the specificity is very high, then
we got like this is the first of the studies. You need more larger number of, because this is so the recommendation which we have made after discussion. The recommendation is gene expert right now as a standalone test for colonic tuberculosis or intestinal tuberculosis. Even if it is not necessary, and if it is positive as a standalone test, does not confirm the presence of colon. It suggests it's something like Montrose test at the moment. Yes, over a period of 1 year, the thing may change as we get more data. But as of today, the best test you have in terms of confirming tuberculosis, if you get a biopsy which shows caseating granulomas, if you find acid-fast bacillus stain positive on those biopsies, or you do a chest X-ray and you find concomitant pulmonary tuberculosis. Gene expert by itself is a good test, but for pulmonary tuberculosis, it requires more study.
What about blood testing? Are you using blood testing for interferon gamma?
no, that is all the serological tests in India are banned. And interferon gamma is only to be used to suggest, again, if you're suspecting, if you want to add something, but not.
If you had a colonoscopy with a positive inflammation, there's an ulcer, there is a inflammatory mass, and my PCR was negative, or gene strip was negative, and I would first do a blood test on interferon gamma before I would consider the diagnosis of Crohn's, because if blood test is positive, then you have to treat for TB before you can do that.
We have ample number of patients and data to suggest that. But interferon gamma release assay, again, like we find it positive in Crohn's disease patients also, and these are patients who have been followed up for years. So we know, we are very sure about the diagnosis.
There is a recent paper from
there are 2 meta-analysis which are available.
They have shown that there is a value, at least the published literature guides us that as you know, we talk about sensitivity, specificity, but there is another very important statistical test called positive predictive value and negative predictive value. What is the positive predictive value for Crohn's? In my practice is very high because everybody has Crohn's disease. Here, the positive predictive value of Crohn's is low, but the positive predictive value for tuberculosis is very high. So you have to put the situation in context.
That's where I'm coming to, because in your practice, you would see 1 case of TB a year, intestinal TB.
1 case every other year, maybe.
Every other year. So here, let's say if I get 10 new cases a week, I would say 5, 10 new cases of this kind of disease a week, then I would be seeing 5 cases of tuberculosis and 5 cases of Crohn's disease, right? And as you know, interferon gamma is a Th1 response.
Yes.
It's something which can be released both in tuberculosis and in Crohn's disease. In tuberculosis, it's a marker of latent TB rather than active TB.
Yes.
So as of now, I agree with you that there is published literature from Korea and Hong Kong which suggests that interferon gamma release is a good way to differentiate between tuberculosis and Crohn's disease. But in our daily practice, what we have seen that it has not been found to be helpful. In fact, when we included patients in the vedolizumab trial, then most of our Crohn's disease were IgRA positive.
I see.
And that became an exclusion criteria for them.
I think this is an important message for the viewers that if this.
So one of the so what if I have to summarize what we have done so far is, so if a person has a diarrhea, more than 3 stools per day, change in frequency, and if it is lasting for more than 4 weeks, he should be evaluated. For evaluation, the second question he should start thinking is, am I dealing with small intestine or a large intestine? If he feels that clinically it is a large intestine, he refers him for a sigmoidoscopy. Let the specialist decide whether he wants to go ahead further and see the colonoscopy or not. He will be able to rule out ulcerative colitis. If ulcerative colitis has been ruled out, let him think back, am I dealing with the irritable bowel syndrome? Have I missed my diagnosis?
And please include put in out here hemorrhoidal bleed. Most of the times these patients are labeled as having hemorrhoidal bleed and they go on for at times months and years.
That's correct.
And then if clinically he thinks that if my patient is having a small intestinal diarrhea, he goes for a routine GI endoscopy, upper GI endoscopy, let him see the stomach and the duodenum, do a duodenal biopsy. With duodenal biopsy, one should be able to rule out the celiac disease, giardia, which is a common inhabitant there, and he should also be able to differentiate between sprue and other types of colitis. If he finds that the upper GI endoscopy is normal, then he has a choice. For capsule endoscopy, no, he should not take a decision for capsule endoscopy because that's the last resort. So he has two choices, either he goes for a CT enterography or a MR enterography, versus he goes for a this colonoscopy with a terminal ileum examination. So let that choice be taken by the GI person, the person who is treating, case per case. So let the GI person for whom he is sending for an opinion take a decision, take a call, whether he's going for a CT enterography, which may be easier. Some people may even prefer MR enterography. Let them choose depending upon the expertise available. Once they diagnose that this is a terminal ileum involvement, then let it be differentiated between tuberculosis versus Crohn's, because the management of both are different. And if you have not been able to differentiate between the two, you can still go ahead with the ATT trial. So you need a tissue biopsy, and you need a visualization for a follow-up condition. Is this the correct approach as algorithm?
We would agree on this. I
Yeah,
think
you
you're
summed it up
very, very excellently summarized. I thank you. Yeah.
So we need, apart from that, we have done the GI endoscopy, we have done everything, but we still, don't we need to rule out chronic pancreatitis, calcific, or to HIV in these cases?
So if you look at the flow chart of the algorithm, what we also do is that initially when we are before the CT scan or something, one may also do if the patient particularly complains of abdominal pain radiating to the back, or patient complains of steatorrhea, foul smelling stools, suggestive of a lot of fat in the stools. Then in a simple abdominal X-ray at times gives you the diagnosis. An abdominal X-ray will show, plain abdominal X-ray will show pancreatic calcification. In cases with small bowel diarrhea, we also advocate to do a HIV serology test so as to rule out a HIV enteropathy that is also a cause of chronic diarrhea in these patients. And before doing a CT, one should also obviously one examines a patient, and if there is any presence of this presence of ascites, then in that case, before you may not need to do a CT enterography at all, and you can simply do an ultrasound examination, confirm that the patient has ascites, and the ascitic fluid can be tapped, and the characteristics of ascitic fluid will help you in making a diagnosis of abdominal tuberculosis. Because abdominal tuberculosis can have three forms: the peritoneal form, where it presents with ascites; intestinal form, where it can involve the small or the large bowel, presenting as strictures, ulcers; or it can also be the lymph nodal form, which presents only with lymph nodes, which will be picked up on ultrasound or CT. So these are other investigations which should be kept in mind while investigating.
May I add one more point to this? So if the focus of the discussion today is chronic diarrhea, there's a very old test that we used to do, which we used to do right stain on the stool or stool fecal leukocytes. That's a very quick test for particularly a general practitioner to send to see whether the patient has inflammatory diarrhea or non-inflammatory diarrhea. Crohn's disease and intestinal tuberculosis will have positive for fecal leukocytes. There is a more modern lab-based test now. It's called stool for calprotectin and stool for lactoferrin. These are neutrophil proteins, and if they are present in stool, the chances of finding Crohn's or TB are much higher than if you would be irritable bowel syndrome. So this is a very quick, non-invasive test that can be done in the community before you even refer the patient, and it being very effective communication between the gastroenterologist, you as a treating physician, and the patient.
When you are evaluating a small intestinal diarrhea, you don't forget to do an abdominal X-ray to look for any pancreatic calcification, and don't miss to do an ultrasound to look for presence of lymph node, which can be suggestive of tuberculosis. Ascites, because peritoneal tuberculosis can be diagnosed easily with the abdominal ultrasound. And yes, and chronic diarrhea with weight loss, always HIV needs to be ruled out. In any way, when you're suspecting a tuberculosis, HIV has to be done, because in every case of suspected tuberculosis, you need to do an HIV. In every positive case of HIV, you need to rule out tuberculosis. And don't forget, the simplest test, which may even be done as the first test, is to find out leukocytes presence in the stool. And if leukocytes are present in the stool, then you know that this is an inflammatory diarrhea. And today, if you don't want to do a simple leukocyte, you have sophisticated tests, which also indirectly tells you about the presence of leukocytes in the stool, and that is stool prolactin test. So if you do all these tests and combine everything together, you should be able to manage a case of chronic diarrhea very well. And remember, a good family physician is the one who suspects and refer the patient to a specialist in time, and your patient will never leave you. He'll always come back to you because you suspected in time and refer the patient in time. And just to add that if the person is elderly, of course, you need to rule out a cancer, which is very, very common, for which in any way the colonoscopy will become the investigation of choice. What we have done in this segment is basically how to approach to a patient with chronic diarrhea. So after watching this module, all the practicing family physicians should be able to timely refer a patient with chronic diarrhea. That's all in this show. We'll come back with one more module. Till that, goodbye. Thank you. So let's thank Vineet for being here with us in this show, and also Vijay for being here with you.